to another edition of the Osteopathic Lyceum podcast. Going to continue with the two-part series, even though it's really just subsequent podcasts about clinical reasoning. What I did previously was talk about what I would call the relative leading edge with respect to clinical reasoning in medicine. And the big takeaways there is if you're fast, you're probably more accurate. If you're faster in coming to your decision, you're probably accurate. The type 1, type 2 thinking, or the type 1, type 2, the dual process thinking doesn't really do much. Errors come from both. The cognitive debiasing approaches don't work. And if you're slow, you just don't know, right? So being reflective about your thinking doesn't seem to do much because you're the one doing the thinking. You often need more information in order to improve accuracy. The ability to utilize knowledge in a way that will call the appropriate knowledge into the circumstance does make a difference, right? So I'm going to start to highlight some of the stuff that I was able to find. Now, I'm not grabbing everything that I could find with respect to the research on clinical reasoning in osteopathy, but the general deal is you start to see this popping up around, I think 2013-ish is what I sort of remember. Might have been a bit before that, but I started to see some of it in around 2013, or its dates in and around 2013. So it's somewhat nascent or somewhat new compared to the research that I've been able to identify in other, at least in medicine, not other fields, but in medicine. Let's be fair. The reason I wanted to do the other one first is so that you can have some comparison with respect to what's going on in osteopathy, right? So the first paper we're going to point to here is, when is this from? It's from 2013. Yeah. What? I lied. It's from the International Journal of Osteopathic Medicine in June of 2014. The title is Diagnostic Reasoning in Osteopathy, a Qualitative Study. Oliver P. Thompson, Nicole J. Petty, and P. Moore. Please excuse me while I clear my throat. I probably should have moved farther away. I'm sorry. When you see qualitative study, you recognize that it's going to likely be from words or observation of qualities as opposed to previously agreed upon numerical measurements. It's a constructivist grounded theory. So there's grounded theory and then there's constructivist grounded theory. The difference primarily is so grounded theory is you get data, you code, you do constant comparison. So as you're going through the data, you're looking for things that are similar. You create a code or a concept that the data would fall into as a category. You keep comparing, you keep refining, you keep comparing, you keep refining until you come up with your codes. Those become your themes. The difference between regular grounded theory and constructivist grounded theory is constructivist grounded theory will acknowledge the impact of the people doing the coding, doing the data interpretation. When you see constructivist, you start to recognize that you're going to have a harder time coming to agreement between groups. So this group would come up with these themes and this idea, whereas other groups may not come up with them. They may come up with other ones. The main takeaway here with constructivist grounded theory is that osteopathic practitioners, the ones that they interviewed, use a hypothetical deductive approach and pattern recognition for diagnostic reasoning. That's pretty consistent with what is known with respect to diagnostic reasoning, generally speaking. Is it diagnostic reasoning? Let me be 100% sure that it's actually diagnostic reasoning. Yes, it's diagnostic reasoning, coming to accurate diagnostic concepts. Now, you have to be really careful with the word diagnostic or diagnosis in osteopathy in most parts of the world because the legal frameworks under which it is performed don't necessarily allow for the term diagnosis to be appropriate because it's done by those in protected professions or regulated professions, and it's not regulated everywhere. Osteopathy is not regulated everywhere. But the hypothetical deductive approach is what medical physicians or medical practitioners do regardless of level. It's just the ones that are more expert compared to the ones that are more novice. The experts are more often right, or they have more knowledge that they can appropriately call on in the new situation to utilize to be more accurate, and therefore it looks like intuition and they're faster. So that's one. The next one. The title of this is Influence of Perceived Difficulty of Cases on Student Osteopaths' Diagnostic Reasoning, a Cross-Sectional Study. This is from 2017. The takeaway here is that the general complexity or the perceived complexity made students go to analytical reasoning. They slowed down and made more errors, right? So we've seen this before. If people are slow, they don't know, right? So they slow down. If they perceive it as complex, they slow down. And that means that they're probably having a harder time either identifying the knowledge required to make the diagnostic choice, or they don't have it, right? Or they do get thrown off by that. The suggestion here is that osteopathic education should support non-analytical diagnostic reasoning approaches. They do note cognitive load challenges. So the more interactivity there is between elements, the more the elements are playing off of one another, the more complex it is, the higher cognitive load is. That is intrinsic load. Extrinsic load is how it is presented. So you can make it sound complicated, which is something that I've talked about with respect to osteopathic education. You can make it sound complicated, and that will make it hard on the learners. The germane load is just kind of, you could call it the RAM or the random access memory, how much thinking it requires just to consider it. They do actually in that one cite one of the papers that I already talked about. I don't remember the name of it, but they do cite a paper. You know what? Let me go and find that to be not crazy here. Keep going. Yeah, there we go. 13. Which paper is it? Reflecting on diagnostic errors, taking a second look is not enough. So we did cover that one in the last one. So at least with respect to, oh yeah, is clinical cognition binary continuous? They have a few articles. They have 3 articles in here. The etiology of diagnostic errors, which we looked at the last time. One that I didn't look at, clinical cognition binary continuous. So there's a few articles in there from the author group that I talked about primarily within the last iteration of this. So I can say with some confidence that as of, where are we at? Oh boy, as of 2017, the profession of osteopathy had some knowledge, at least in written form, of some of the stuff that I'm talking about. So it's not that it's not there. It's there. It's just that it's not necessarily strong or dominant. Where are we at? Okay, we're going to move on to the next one. So the big one there is if you're slow, you don't know. If you make it complex, it's harder to figure out what to pull in. The next one, where are we at? Is understanding clinical reasoning in osteopathy, a qualitative research approach. This is 2016. This is constructivist grounded theory again. So remember that the authors are essentially saying that they are they're embedded. The conclusions, the interpretation is embedded with their values, which is pretty normal. It's not that weird. This is from Australia, New Zealand, and UK. The thing here, they did the interviews. It's hard to know exactly how they pose these questions because some of them are semi-structured interviews. So you ask questions, you're going in a general direction, but the questions may be variable, and you're just generally trying to build themes. The thing that came out of this is that the osteopathic practitioners that they asked, that they did these interviews with, say that they use an initial biomedical screen to identify serious pathology. Then they go to a structure-function relationships and how they think about stuff to choose the treatment approach. So sometimes if you ask people questions in particular ways, they'll tell you preferences as opposed to what they actually do. So I'm not 100% sure about how these interviews went. My initial sense is that they might have been formulated in more of a dichotomous way. So what they were being asked is it's like a how you do this thing, but people weren't necessarily questioned in a way, or the method didn't allow for exposition and observation of how it was done. It was, how do you think you do it? And often people who do things, when they are asked to explain them, are not good at being explicit about what they actually do. What you think you do and what you actually do may not necessarily match. And I'm going to at least say that here, not knowing about how the semi-structured interview was done. But yeah, to go to the structure-function relationship, which is tenuous, and I've talked about, anatomical possibilism. So there's an article that was in the Journal of Osteopathic, in the International Journal of Osteopathic Medicine, coining that term, anatomical possibilism. Just because the anatomy's there doesn't mean that things work that way, and doesn't even mean that we properly understand the anatomy in the way that we think we do. I don't see general acknowledgement of variability in anatomy within the osteopathic profession. It seems to be presented in my observation as a stable thing when it is a variable thing. So there's some challenges there. But yeah, you ask people, how do you do it? They tell you how they think they do it. You're better off to watch how they do it, observe how they do it, as opposed to ask them how they think they do it. So I have a challenge there. So the reason I bring that one up is to just note some of the challenges with how the discussion may be going. The next one, let's get to this one. This one is from 2018, Clinical Reasoning in Osteopathy, Experiences of Novice and Experienced Practitioners. What do they do? This one is semi-structured interviews based on reflection from 2 case studies. So they presented 2 case studies, and they asked you how you did it. The claim is here that osteopathic clinical reasoning is different because it relies on experiential findings in the form of observation and palpation of the patient. I don't know how many of you have been to a physician. They use experiential knowledge. They observe you. Some of that observation is listening to what you're saying, but it's observing you visually, also taking things like vital signs. And they do palpate. They may not palpate all the time, but they do palpate. So this one is tough because it's like, well, osteopathy is different because it's hands-on and experiential. It's like, yeah, all healthcare practices are. If you're going to say that, then you're going to have to say that about chiropractic and massage and physiotherapy, regardless of what the chiropractors, the physios, or the massage therapists say. It's going to rely on palpation and observation and experience. So yeah, this one isn't all that useful. What's the next one? Where are we at? This is from 2018 as well. Osteopathic Clinical Reasoning, an ethnographic study of perceptual diagnostic judgments and metacognition. So the metacognition, that is an alarm bell or a red flag for dual process thinking, or dual processing, so cognitive bias type stuff. This was done by one practitioner, talked about how they were doing the diagnostics, and then the authors then extrapolated from that. It's suggesting diagnostics are multisensory, so they use they use the term mental imagery, visual imagery, and embodied senses. So embodied senses would be, palpation, audition, vision, right? Then they're saying you have in your mind's eye, whatever, probably anatomy in this case. They end up suggesting the support for metacognitive strategies, which is dual process theory. Just remember, cognitive debiasing, stuff that is based on the strategies of the dual process theory, does not work. The person doing the thinking doesn't know the error they're making because they're the one making it. So it doesn't work. I appreciate the attempt, but this is one person talking about how they were thinking. And it's like, yeah, I use my eyes and my hands, and sometimes I smell stuff. So it's like, what the heck? Next one. Cognitive biases in osteopathic diagnosis, a mixed study among French osteopaths. This is from 2025. The moment you see cognitive biases, this is dual process theory. Cognitive debiasing doesn't work. It doesn't work. It doesn't work. It doesn't work. The person making the error doesn't know they're making the error, so making them think about how they're thinking doesn't work because they're the one doing the thinking. Okay? This is, I think, the most recent one in this list that I've got here. what the heck? Yeah, so they made it sound really fancy. They did quantitative and qualitative. The quantitative is a survey. So depending on how the survey is set up, it can mess with things. Surveys always have inherent challenges. People who will answer them are similar to one another. Also, there is a social desirability bias. People tend to answer in ways that they believe will not get them kicked out of their perceived group. So there's generally problems. And then they did focus groups. So they're just saying metacognition, cognitive debiasing. Again, red lights, red flags, doesn't work. Don't keep going here. Now this one is from 2019. Reflective practice enhances osteopathic clinical reasoning. If you're listening to this, you can't see my face. No, right? Here's the highlights. Reflection underpins all osteopathic practice in CPD. Reflective practice and knowledge of metacognition may help prevent error and bias. Nope. Reflective practice facilitates practitioners to improve patient care. Everybody's going to reflect when they screw up. When everything's working, it's less likely that they'll reflect. Reflective practice should improve practitioner wellness and job satisfaction. Not if it's mandated. People who are going to reflect will just do it. People who aren't going to reflect or to have no motivation to reflect or impetus, no. Like, whatever. What did I write about this one? So they record diagnostic thoughts when they're verbalized, and then they turn that into a reflective narrative. Then they do grounded theory. They note that reflective practice helps practitioners become aware of their thinking. If you think about your thinking, you become more aware of your thinking because you're having to go back over it. It also likely changes the process of your thinking. It's not how you would normally think. You're being asked to note things. And when you note them, they come to more conscious awareness because there's a conscious effort as opposed to the processes that would run in a different way, an undescribed way and an unexpressed way. Yeah, they say metacognition will reduce errors. Like, this is, unfortunately, the general state that I am broadly, very, very broadly seeing is that the thing that has been spoken about, or that I noted that was from the author group in the first of this iterative series, with respect to Dr. Montero, Dr. Norman, Dr. Sherbino, Dr. Sybil to some degree, and a variety of other authors, depending on the paper, is that this cognitive debiasing and metacognition, it's not going to do anything. Right? The general thinking skills. No, these are very specific skills with respect to diagnostics. Now, this gives me the opportunity to turn into a general description that considers a bunch of different things. So one of the things that you are likely to benefit from, and that was noted within one of the papers here that I just presented in this particular episode, is that there is some consideration of cognitive load theory. So intrinsic load, the interaction of the multiple elements of a thing. So the more interactive elements, the more complicated something just is. There is the extrinsic load, or how it is presented to you. It can be a simple thing can be presented complicated, and then your load goes up, and then there's your main load. Just the kind of the general background thinking resources that you need to do to consider a topic or to think about a topic. The more you think about things that are unobservable, the more complicated things will be to thought. Not necessarily to reality, because they are just as complicated as they are to reality, but it is the thought that can make things more complicated. So if you are thinking about things that are not directly observable, aka anything other than the observable movement, and anything other than what you can see, hear, or smell. Hopefully you're not tasting your patients, because you shouldn't do that. That's wrong. But just the general senses that you can gather from your patients. The moment you start thinking about the anatomy that's underneath it and start naming it in specific ways without acknowledging that it's variable between people, it is variable within the same person, side to side. There is variance. It may be minor, but there is variance. If you don't note that, then you're going to be more likely to be wrong, more likely to make errors about the claim and what you're thinking about that's not directly observable. but your actions can still be accurate to the situation, because if you find restricted movement either on a macro scale or on a yield to pressure for soft tissue scale, if it changes, you're accurate to that finding. But when you describe it and when you think about it, you're thinking about more interactive elements, and you are more likely to be wrong if it's not what you can see or what you can feel or what you can hear. So you're driving the cognitive load up. When you tell people to think about the anatomy that's under their hands at all times, and all the layers and all the positional anatomy and all the functional anatomy, you're making it more complicated than it has any requirement to be in thought, which may impact action. So if you just take that general thing where there was the perception of increased complexity, yeah, maybe you can paralyze your students by telling them that this stuff is really complicated. You have to think about all these nerves and arteries. It's like, yeah, but the artery may not necessarily run the same course. The nerve may not be in the same place. It's going to be variable. The location of terminals and location of choke points and the layout of the fascia is different. So just give it up, right? You need to know the anatomy so that you have a general understanding of a general blueprint, but don't force people to think about it all the time. It makes them less accurate. It makes them make more errors, and it makes it harder for them to make decisions. And it makes it more likely they're going to make funky, weird decisions, right? When you watch how people are practicing and the rationale that they provide, it's all over the place. It is disheartening sometimes. But if you're looking at how the thing is moving, or observing how it's moving, and in a tactile sense, identifying resistance to motion, you're going to be pretty damn good. And if you can stay there, you're making less assumptions. You're making likely less errors. And if it changes, then you're doing what you need to do. Your explanation of it, you can make it as complicated or as simple as you like. But the more complicated you make it, it's probably going to make it harder for you to make accurate decisions. Then we consider the hypothesis. The basic hypothesis of osteopathy is that there is a mechanical relationship between health and disease states. If there is a mechanical relationship between health and disease states, that then overlays and is background to all decisions about what you find. Your finding is either going to be a macro motion, whether it's active or passive, the patient moves themselves or you move the patient, and then it's going to be about yield to pressure for soft tissues. It squishes or it doesn't squish. If it doesn't squish the way the other areas squish, that is where you work. So squishy, squishy, no worky. Squishy, no squishy, worky, worky. You work where it doesn't move, where it doesn't yield, where it doesn't do what its neighbors do or its pair does. You're going to be really accurate there, okay? Under the hypothesis that if you alter the mechanical dysfunctions that you identify, that nature will take care of the rest. So we look at what Dr. Still is purported to have said as put forth by, I think it was Webster, G.V. Webster, in 1910. He put the quote forth that I believe, as long as I'm not screwing up, because I'm not exceptionally sharp on that. I didn't do the find it, fix it, leave it alone recently, but I have looked at it recently, so I think it was Webster. But it was purported or quoted as Dr. Still having said, find it, fix it, leave it alone. And the general thing that you'll see in Dr. Still's actual writing is you identify the mechanical restriction, you alter it, you remove it, nature will kindly take care of the rest. Because the hypothesis is that the mechanical dysfunction identified, when altered, if it is related to the problem will then change. The body will self-heal and self-regulate, right? So you don't actually have to do that much complicated thinking about this. Just find where it doesn't move, get it moving better in a way that is responsive to the patient. So if you use the heuristic approach that I talk about, now I'm not using a heuristic approach in the way that the dual process thinking is using it. I'm using it as the definition that I provided in the past. It was from some artificial intelligence research in 1985 that said an algorithm was a set of steps that guaranteed a solution versus a heuristic was a set of steps that generated possible solutions to test between. So you have an organized way to develop your hypothesis or your solution set. Your solution set, in a technical sense, is how you're holding or how you're physically interacting with the area that you want to improve movement in, the positions that you've chosen to put the patient in, or the position you've chosen to put the patient in, then whether you go direct or indirect, whether you go patient active or patient passive, and then whether you go long lever, short lever, things of that nature, right? So the tissues that you're going to target are the ones that don't move, regardless of their names or regardless of what you think about them. You're going to go direct or indirect, and the patient's going to be active or they're going to be passive. You can just choose to go passive or active first, and then if it doesn't work, you do the other one, right? There is a way to choose through this. So if you pick back through a bunch of the material that I've put forth before, you'll start to understand how these work together, right? So if the basic hypothesis of osteopathy is there's mechanical relationships between health and disease states, that's an autofill. What if you fix or alter all of the mechanical restrictions that you identify and the problem that the patient is presenting persists? Well, then the hypothesis is null. You have shown that the problem isn't related to the mechanical dysfunction that you identified, especially if it changes. You've still done something good for that person because you've changed that mechanical dysfunction. So on some level, you've altered their function in a positive direction, but it hasn't related to the complaint or the presentation. It isn't always going to, but you get to test that hypothesis at all times and see how often it pans out or how often you're able to support it and increase your confidence that it's correct. It's correct often enough. There are a good amount of times when the mechanical dysfunction relates to how the person feels in a way that when you change the mechanical dysfunction, their presenting circumstance or their presenting complaint changes in the way that they want it to change. But you're testing it all the time. Instead of choosing the method from the diagnostic, if you use a general decision-making approach that is consistent as a framework, you can identify the most appropriate method for the patient in the moment instead of choosing a method and then having to choose another method. You just have a general process that you run through that says, okay, well, if I'm going to go, we're going to start off, say, long lever. I choose long lever. As I move the long lever, if everything's jumping around and it's not staying well controlled, okay, well, I'll take elements out. I'll go short lever, right? If I go passive, patient passive, and I just can't quite get it to work, it's not really connecting the way that I want, then I'm going to go patient active, right? I can just choose passive first and then go active, or I can just choose active first and then I can go passive. The barrier, well, if I go in the direction of the direct barrier and they say, ouch, I don't go that way. I go indirect. I make the soft tissue soft. So the decision point there is patient-centered. Did the patient respond positively? With respect to active or passive, are the tissues jumping? Are they protecting themselves? Because you don't want to make them say ouch, right? The barrier concept guides you to not make them say ouch or not generate protective responses. There's a set of decisions here that can be consistently utilized in all circumstances that will help you zero in on the method that's going to be most effective for the patient, as opposed to just saying, okay, here's my findings. I think I need to do strain, counter strain, right? Those previously named systems and codified systems are boxes that may make it so you pay more attention to the system than you do to the patient. So you have to be very careful with that, or you benefit from being careful with that. But the basic hypothesis to minimize the cognitive load of osteopathic practice, there's a mechanical relationship between health and disease states. Find the mechanical dysfunction, change the mechanical dysfunction in a way that doesn't make the patient say ouch. So the barrier concept, central to osteopathy. And if their presenting complaint changes, then they were properly related. You have supported the hypothesis. If they don't change, right, or if the presenting complaint doesn't change and you did change the movement objectively, then they're not properly related, and another approach is more likely to work for that patient as long as they're willing to approach it, because sometimes patients aren't willing to approach certain other healthcare interventions. So you should be willing to be aware of that part. Overall, as far as I can tell, the state of clinical reasoning in osteopathic clinical reasoning research in osteopathy is very much behind the leading edge. I have reason to believe that there is some awareness within the profession of what the leading edge is. It's just not being utilized, which is okay. It'll get there eventually, but you want to be careful with things like cognitive load, the dual process theory stuff. It's a dead end as far as the ability to impact improved accuracy or reduce cognitive load, because if you're slow, you don't know. So if you ask people to slow down, you just made it more complicated. If you ask people to think about all the anatomy at all times, they're more likely to make errors. They're more likely to be less attentive to the patient in the moment. If you ask people to import previously codified systems, so strain, counter strain, facilitated positional release, myofascial release, what else? Muscle energy, whatever you ask them to import, think in those ways. You take them to the system, you increase the complexity, you increase the cognitive load, you decrease the attentiveness of the patient, you decrease the patient-centeredness. This is an argument that I've been developing over time. If you've been consuming the material that I've presented, maybe you'll have some better understanding of it. I'm not 100% sure. I think I'm doing a good job, but as metacognition and reflection research show, whatever error I'm making, I'm not going to be doing a good job of understanding that I'm making it, because I'm making it. You're observing me make it. So the benefit of external input of an expert to observe and provide feedback on the errors becomes very important. So in the educational sense, the primary role of the instructor, or the best role of the instructor, is to help somebody work on the process of decision making and provide feedback on the specific error committed when observed. So then the person knows they committed the error and can start to make the correction based on the appropriate information. They can start to learn from experience what types of errors they have made, minimize those, develop strategies because they know they made it, figure out which knowledge to put into the situation, do that over and over and over and over, iteratively, screw up while being observed, get feedback, improve, screw up while being observed, get feedback, improve, and then that develops the experiential base. And if you do it based on a decision-making framework, then you're always working on clinical reasoning, clinical decision-making, diagnostic reason, diagnostic decision-making, whatever term you want to use, it's always being worked on if you set the education up the right way. So hopefully this actually shows a bunch of the stuff I've said in the past together a little bit better, so that it's more understandable why I suggest the things I suggest. Maybe this has helped some of you who have listened for a while. Maybe it hasn't. But the big deal, stop chasing down dual process theory. Stop chasing down metacognition and reflection. It's not going to cut it. The expert observer will identify the error, provide the feedback. The learner will know they made the error. They will start to make corrections. They will build a greater semantic network, a greater network of related knowledge or related meaning, and they will get better. And if you want to use the traditional approach to technical teaching in osteopathy, strain, counter strain, facilitated positional release, functional technique, myofascial release, muscle energy, whatever system you want to use, LASBLT, you are making it more complicated. They have common elements. You can teach those common elements. You can teach a framework for testing between those common elements to see what the person responds best to right now. And your clinical reasoning becomes much lower cognitive load, much more straightforward, much more attentive to the patient, much more patient-centered. It's probably a better way. And because I've designed my program in this fashion, you'll say, of course you think it's the better way. Well, if you have time, go back through all the stuff I've put out and you'll see the supporting evidence. I'm happy if people disagree with me. Bring your supporting evidence. I'm interested to see it. So hopefully you've learned something. Thank you for listening this far, and we shall talk again soon.